Welcome to a session on the motor and sensory nuclei of the cranial nerves. In this session, we will be differentiating between different levels of the brainstem in cross-sectional images, associated cranial nerves with each of those appropriate brainstem levels, identify the sensory and motor nuclei in cross-sectional images of the brain, of the brainstem, the fiber types associated with each of those cranial nerves, the structures that are innervated by each cranial nerve, and then describe how a patient might present with damage or a lesion to each of those cranial nerves, and identify the vascular supply to each of those levels of the brainstem, which may be influenced if there is damage to that blood supply to a particular portion of the brainstem. As a general perspective, we should recognize that the brainstem has multiple functions. It plays a very important role in controlling autonomic functions in both cardiovascular and respiratory, as you've discussed in other blocks. It has a critical role in regulating sleep and cortical arousal via the reticular formation, the central portion of the brainstem, and has a critical role in consciousness. It is also a conduit for pathways that are coming from the cortex down to the spinal cord, and those from the spinal cord going up to the brain, up to the cerebral cortex. And it also has critical cranial nerve functions. We'll be focusing on those. If we look at the various components of the brainstem, we can first divide them between those that are sensory nuclei within the brainstem and those that are motor nuclei within the brainstem, and which of the cranial nerves they are associated with. And you can see those indicated here on the left for the sensory nuclei, and those for the right on the for the motor nuclei. And recognize that there are groups of general somatic afferents, special sensory afferents such as the vestibular cochlear nerve, as well as special sensory afferents involved in taste, the gustatory nucleus, and a general visceral afferents involved in the solitarius. On the motor side, we have a number of motor nuclei that are involved in the eyes, the oculomotor trochlea and abducens, a major motor nucleus involved in moving the tongue, the hypoglossal nucleus, as well as some branchial nuclei involved in motor for the face and muscles of mastication, as well as the larynx and pharynx. And then general visceral efferents for pupillary constriction and a variety of glands and viscera. We recognize also that the sensory neurons that receive input play a critical role in certain blink reflexes, that is in the corneal blink reflex, the gag reflex, that we'll be using to assess function within the nervous system in the brainstem. And also the motor neurons have the motor nuclei that we've mentioned for skeletal muscles as those for smooth muscles and glands. A couple of general concepts about brainstem organization. The motor nuclei are somewhat more medially located, and the sensory nuclei are more laterally located. Keep an eye to where the long track pathways are located at each level and follow them as we move up through the brainstem. And then finally, note the distribution of the blood supply at each level, both what supplies the medial portion of the brainstem, what supplies the more lateral portion of the brainstem at each level, because they turn out to be important when there are strokes in any of those vascular distributions. For a schematic, we want to recognize that the brainstem cross-section emphasizes the medial location for motor nuclei and the more lateral location for sensory nuclei and an intermediate position for autonomics. The motor nuclei are basal plate derivatives, the sensory nuclei are alar plate derivatives. If we think about the brainstem as an elaborated spinal cord, we can recognize that the ventral horns, which are located ventrally and medially in the brain, in the spinal cord, are also located ventrally and medially in the brainstem. But because of the opening up of a fourth ventricle, which is the equivalent of the spinal canal in the spinal cord, the sensory nuclei, which would have been the sensory input, the dorsal horns, rotated out, and the sensory nuclei in the lateral position are the equivalent of the dorsal horns in the spinal cord. And we see those represented here for the sensory inputs, the motor outputs, somatic motor and somatic sensory. And we recognize that the visceral sensory and the visceral motor nuclei tend to be located in between these somatic sensory and somatic motor. If we look at a ventral view of the brainstem, we can see moving from the medulla through the pons and the midbrain, the location of the cranial nerves, and recognize that cranial nerves 3 and 4 come out of the midbrain, 5 through 8 come out of the pons or the pontomedullary junction, and cranial nerves 9 through 12 come out of the medulla. And we'll be looking at their location and the origin. Only one cranial nerve 4, comes out of the dorsal surface of the brainstem, as we see here, but then it wraps around the brain. If we were to look at the major pathways that travel through the brainstem, going from spinal cord all the way up, starting up at the and coming down from the cortex, corticospinal tract that you've examined, occupies a medial position and relatively inferior or ventral, and the corticobulbar pathways, which are paired with the corticospinal pathway, but instead of going down to the spinal cord, the corticobulbar pathways come from the cortex and travel down to the brainstem and synapse at motor neurons in the brainstem on the contralateral side in general. The medial lemniscus, which carries information about vibration, position, and fine touch, is initially located in its medial surface. That's the continuation or the secondary neurons from the dorsal column neurons. They start out in a medial position lower in the brainstem, and they gradually travel more laterally, while the spinal thalamic tract information, which originated in this lateral portion of the spinal cord, will travel up and continue in a lateral position right up through the entire spinal brainstem. We can also see the major blood vessels in this setting, and that is the basilar artery, the major blood vessel feeding the base of the brainstem, and it is fed by the vertebral arteries, but it has major branches that travel laterally, and coming off the basilar artery are 3 major vessels that we'll be looking at later on: the posterior inferior cerebellar artery, anterior inferior cerebellar artery, and the superior cerebellar artery at various levels of the brainstem. This is at the medulla, at the pons, and up at the midbrain. If we look at the blood vessels in place over the brainstem and the spinal cord and the cranial nerves, we can see those vertebral arteries coming together near the medulla, and they provide supply to the anterior spinal artery. They also provide supply to the posterior inferior cerebellar artery, either off of the vertebral arteries, or the pica may come off of the basilar artery. The basilar artery is the major trunk here, and then you see the aica coming off at the pons, superior cerebellar artery at the ponto midbrain border, and the posterior cerebral arteries being the termination of the basilar artery going out to lateral portions of the hemisphere and to the occipital cortex. Here we begin to see the location of the major cranial nerves, nuclei, for motor function. So we see, starting out in the midbrain, nuclei for cranial nerve 3, for cranial nerve 4, also in the midbrain, 5, and you notice that most of these are relatively dorsal in the midbrain relative to the basis pontus, which takes up a great deal of the Pons. And we see cranial nerve 6, cranial nerve 7 nuclei, as well as the salivatory nucleus is right near by in the Pons. As we come down to the medulla, we can see the nucleus ambiguous, having fibers for cranial nerve 9. We can see the dorsal motor nucleus of 10, which has fibers coming out for cranial nerve 10. And then we can see that nucleus ambiguous has these fibers coming out for 9 and 10. And we also see cranial nerve 12 coming off right here. If we look at down at the brainstem from above, we can see that those motor nuclei are that is 3 and 4 and 6 motor nuclei, highly localized medially. We see hypoglossal nuclei, highly localized medially, and as you go off to the sensory nuclei, you find them a little bit lateral, but these motor nuclei are very highly localized medially, the facial nucleus as well as 9 and 10, the ambiguous nucleus. General somatic efferents are 3, 4, and 6, which handle primarily eye movements, and 12, which handles primarily. If we look at the oculomotor nucleus, we can see in the periaqueductal gray, just in the inferior portion, we see the oculomotor nucleus, just ventral to the cerebral aqueduct, and it sends its fibers down to the ventral outlet. We can also see those fibers coming out at this midline. Recognize this is the red nucleus. These control extraocular muscles, multiple muscles, for adduction of the eye and elevation of the eyeball. If we look at the midbrain, and this is a location in which we have the periaqueductal gray again, we see the 4th cranial nerve nucleus, trochlear nucleus. We also see the inferior colliculus as an indicator that we're in the midbrain, and we see the crus cerebri and the substantia nigra, which will become important for us when we study Parkinson's disease. If we look at the pathway for cranial nerve 4, we see that it leaves these cranial nerve nuclei and then it goes dorsally and crosses over to the other side. And it moves the eyeball, it rotates it and moves downward. If we look at the 6th cranial nerve nucleus, we're down now in the caudal pons. We see the 6th cranial nerve nucleus sitting right here, and we recognize this middle cerebellar peduncle coming from the cerebellum, and recognize the 6th cranial nerve nucleus, which sends its fibers down again to the ventral surface on a medial course, and they are involved in abducting the eyeball, ipsilateral eyeball. If we look at the hypoglossal nucleus, it's again in the medial region, and it sends its fibers down between this is in the medulla, between the pyramids and the inferior olivary complex, and it sends it out in that pre-olivary sulcus again to a ventral position to control movement of the tongue. You see here somebody who has a lesion to the hypoglossal nerve and has damage to the same effect with damage to the nucleus or to the nerve. And in this case, when they ask to stick their tongue out, tongue goes out to the side of the lesion of the cranial nerve or the cranial nerve nucleus. And it's an indication of the appearance of a lower motor neuron damage. The branchial efferents involve cranial nerves 5, 7, 9, 10, and they control a variety of movements of mastication, facial expression, and muscles of the pharynx, larynx, and palate. Deviation from these arches, derivation rather, is classified as branchial rather than general somatic efferent because it's tied to the derivation from a somi. The trigeminal motor nucleus of 5 is located in the pons, and it sends its fibers, a very large group of fibers, as you can see more prominently over on this other side, into a lateral position within the external portion of the pons. And they innervate the muscles of mastication, the belly of the digastric, mylohyoid, and palatine, tensor belli palatine. Facial motor nucleus we see, number 7, initially sends its fiber dorsally and medially, and it then comes around the 6th cranial nerve nucleus and sends its fiber out laterally to control movements of the parts of the face. Damage to cranial nerve 7 produces a Bell's palsy, a paralysis of the entire ipsilateral half of the face. We see cranial nerve 6 coming through much more medially. As we move down to the medulla, we start to see the nucleus ambiguous. It's just above the olive, and it sends its fibers out just above the olive in a lateral position. This is actually 9 and 10 coming out in this location. And it innervates muscles of the pharynx, larynx, and palate. And these are important in the gag reflex that you can use to assess the integrity of this portion of the brainstem. The parasympathetic ganglion neurons that supply cranial outflow to the autonomic nervous system originate in a portion of the cranial nerve nucleus 3, the Edinger-Westphal nucleus, for pupillary constriction and lens accommodation. Other fibers, pontomedullary fibers from cranial nerve 7, 9, and 10, travel in a direction that is designated superior and inferior salivatory nuclei. The dorsal motor nucleus is the source of preganglionic sympathetic fibers in the vagus nerve. We see some of those represented here, and we see 7 and 9 going to these various glands coming from salivatory nucleus. Here we see the Edinger-Westphal nucleus that was just described, just above cranial nerve nucleus 3. And it mediates pupillary constriction and accommodation of the lens. And so you can imagine when somebody's comatose, if you test their pupils, if there's damage to this pathway, which is a brainstem pathway that is nearby the reticular formation, you lose pupillary response. It would give you concern that there is a problem within the brainstem rather than some other location responsible for the comatose state. If we come down to the medulla, we see that the dorsal motor nucleus of 10 of the vagus is represented in the very dorsal position, an intermediate position between medial and lateral. And it's just lateral to the hypoglossal motor nucleus right here. And we see the fibers of cranial nerve, of dorsal motor nucleus of vagus, coming out in this lateral position between the olive and the superior, and the cerebellar peduncle. Go back here a moment. Now, cranial nerve upper motor neurons for brainstem are the corticobulbar fibers. These are motor nuclei are the cranial nerve in the brainstem of lower motor neurons. And they're driven by fibers that originate in this motor cortex and then come down and activate lower motor neurons. They decussate roughly at the level of their target. So cranial nerve 7, the fibers come down and cross over at the pontine level. Cranial nerve 12, the fibers come down from one side and will cross over at the medulla to reach cranial nerve nucleus 12. As a result, upper motor neurons, that is those up in the cortex, will have an effect on the opposite side of the body, while those that hit the lower motor neuron or the nucleus generally will have an ipsilateral effect. And we'll talk about an exception for cranial nerve 7. which gets bilateral input from the two hemispheres. We see here the corticobulbar fibers. Their origin is in the face area and throat area and the tongue area of the lateral portion of the motor cortex, if we look at this cross-section through the motor cortex. And they come down through the internal capsule, and then as they come down to the midbrain, they occupy this shaded piece for corticobulbar fibers, and corticospinal fibers are a little bit more lateral. These are what feed the motor nuclei supplying the head. This whole area is referred to as the crus cerebri. We see here the red nucleus in the midbrain, as well as the medial lemniscus carrying information about position and vibration. And you see the cerebral aqueduct, central gray. In this interesting feature of this cranial nerve 7, and that is the cranial nerve nucleus, a portion of it gets bilateral input from both hemispheres. So the upper portion of it gets input from both hemispheres, while the lower portion gets input only from the contralateral side. As a result, damage on one side, as you see here, to the corticospinal tract, or rather the corticobulbar tract, will produce lower facial paralysis, a lack of the nasolabial fold, but a person is still able to wrinkle the upper portion of their eyebrows and forehead. And you see an example here of somebody who has weakness of the lower facial muscles on one side. So when he's asked to bare his teeth, he can't smile on the other side, and you see an absent labial fold, nasolabial fold. And yet, when you ask him to wrinkle his brow, he can wrinkle both sides of his brow. So that tells us that it's an upper motor neuron lesion to the corticobulbar fibers feeding the face. Here's another person who has damage to the facial motor nucleus, and at that point, you influence the entire face. So this person, when asked to smile, cannot smile on the right side of his face and cannot wrinkle his brow on that side. And that's called the peripheral seventh. And it's most commonly due to viral infections, various tumors, parotid tumors, or mastoiditis. Now we'll start to take a look at the sensory cranial nerve nuclei. And starting up in the midbrain, we can see a mesencephalic nucleus of 5. Cranial nerve 5 has many different nuclei that represent its output. So you have sensory input coming to the midbrain that carry information about proprioception. We have a main sensory nucleus within the pons that carries information about touch. And then we will have a spinal tract nucleus of 5 that carries information about pain and temperature. So those basic sensory fibers that we see in the periphery, both in the head as well as in the body, in this cranial nerve are sorted out into very discrete nuclei within the brainstem. And we also see nucleus solitarius that has information coming, sensory information coming from 7, 9, and 10, and that's information about taste. If we look at those from a dorsal or ventral view, we notice that they're more lateral than the motor nuclei, and we notice that they cover quite a span, particularly the spinal tract and nucleus of 5. You can see that it extends from the pons all the way down, literally to the upper cervical spine. Each of these has a significant extent, and you see that this extent for mesencephalic nucleus of 5 means that it's getting information over an extended portion of the midbrain. On the ventral surface, We can appreciate where the cranial nerves are, as well as where those cranial nerve nuclei are and where they exit the brainstem. What's not shown here, which is important for our consideration, is that you do see cranial nerve 5 coming out here. You see cranial nerve 6 much more medially, and then 7 and 8 would come out right in this region, and you see 7 and 8 immediately adjacent to one another, carrying information, of course, the vestibulocochlear nerve 8 about hearing and vestibular sense, and 7, the facial nerve. As we indicated, the trigeminal pathways to the head have these 3 different characteristics: the main sensory nucleus for discriminatory touch, the spinal nucleus of 5 for pain and temperature, the mesencephalic nucleus of 5 for proprioception for the head and face. When we look at information that's coming upwards from the trigeminal system, we see that it travels from those cranial nerve nuclei for 5 up towards the thalamus. So they synapse in the thalamus, and from the thalamus they distribute over the postcentral gyrus, with the leg most medial and the arm more lateral and the head most lateral. Those from the head are coming through this dark blue line that are coming from the trigeminal system that we see over here. And for the body, we can see that that information was coming from the peripheral nerve into the dorsal root, the dorsal horn, and some of those fibers would travel up in the dorsal columns. They would synapse in the dorsal column nuclei at the spinocerebellar junction that is represented here. At the spinocerebellar junction, they synapse on neurons that then become to form the medial lemniscus. The medial lemniscus sits in this very medial position up through the medulla, and it starts to move laterally in the pons, and the foot moves out most laterally. The hand tends to stay more medially, and then it assumes a much more lateral position when it gets up to the midbrain on its way up to the thalamus. We see here the main sensory nucleus of 5 in the pons, represented in this location. And then we'll look at the spinal nucleus of the trigeminal, and you see here the spinal nucleus of the trigeminal carrying pain and temperature information. It also gets input from other cranial nerves, from 7, 9, and 10. And this is the position of the spinal nucleus of 5. So you have the main nucleus out here for touch and 2-point discrimination, and just below it we have a nucleus and tract of 5, and that runs right next to the spinal thalamic tract because they're both carrying pain and temperature information. This for the head, and the spinal tract coming up from the body carries information about pain and temperature in the body, and that will travel up at this point ipsilaterally up to the thalamus, and then up to the cortex. We can see here cranial nerve 7, and we see the spinal nucleus in this location. But notice that some of those fibers are going to come up into the same area, carrying pain and temperature to the attractive nucleus of 5 that become part of that tract nucleus. We also see here the tractive nucleus of 5 that are getting just generally called the spinal nucleus and tract, carrying 5 carrying pain and temperature, but recognize that 9 and 10 come and join that and differentiate the pain and temperature information from other information that's going to go up to the more medial structures. Recognize also the vestibular nucleus near the dorsal surface, dorsal lateral surface of the medulla. Important for vestibular function. And
The cochlear nuclei have been torn off here, but they'd be represented right out in this position, right next to the cerebellar peduncle. And here we see the spinal tract and nucleus all the way down in the spinal medullary junction, and this is the location at which the dorsal column come up and synapse in the dorsal column nuclei right here, in this more lateral position for the arm and this more medial position for the leg. They will, at just about this level, start to cross over to the opposite side in the same way that the corticospinal tract fibers are crossing from the pyramids, from the corticospinal tract down from the lateral position over to this medial position to form the pyramids. Here in the midbrain, we can see the mesencephalic nucleus of 5, which is in the lateral portion of the periaqueductal gray, and it carries information about proprioception from the entire head. A number of important reflexes that take place in the brainstem that can be used to assess function of the brainstem. The jaw jerk gets sensory information from cranial nerve 5 and activates motor nuclei that go directly out to the masseter and produces contraction of the masseter, and that's a measure of integrity of the pons at the level of cranial nerve 5. You can do that, test that by tapping on the chin and seeing the extent to which that reflex is brisk or reduced. A number of visceral afferents carry information about taste and other general visceral sensations in cranial nerve 7, 9, and 10, and they enter the solitary tract and synapse in the nucleus of the solitary tract in the medulla, and that's a rather bright spot in the medulla. And that provides information about taste, about it's called the gustatory nucleus. And you see it represented here for its special sensory inputs. And there are different types of taste information coming from 7 portions of cranial nerve 7 and from one portion of the tongue, and in the more posterior portion coming into cranial nerve 9. We can see that solitary nucleus right up here, right next to the dorsal motor nucleus of the vagus is right here, and the solitary nucleus and tract as just lateral to it. So damage here would affect the ability to taste. As we indicated, solitary nucleus is close to the vagus, and as a result, some of the influences from one and another turn out to be very important. And these nuclei are important along with the nucleus ambiguous in regulating some of these reflexes and control systems that you encountered for cardiorespiratory control, baroreceptor, and control of heart in various ways. The vagal nerve is also involved in vomiting, and inputs from the vestibular nuclei come into the vagal nerve, and they can induce vomiting. And also, the vagal nerve, vagal complex can be activated by various substances coming into the in through the blood, because there's a different blood-brain barrier, reduced blood-brain barrier in the vicinity of the vagal nerve complex near the margin of the fourth ventricle. And as a result, the vagal nerve complex can detect some of those toxins and produce vomiting to attempt to get rid of harmful substances. We want to look now at the blood supply to the brainstem and recognize that, again, the basilar artery is a major brainstem artery, covers much of the base of the brain, brainstem, particularly the pons. It's fed by the vertebral arteries, which of course provide input to the spinal artery. And again, we're looking at posterior inferior cerebellar artery, covering the lateral portion of the medulla, the anterior inferior cerebellar artery feeding lateral portion of the pons, the superior cerebellar artery covering lateral portions of the midbrain and upper pons and the posterior cerebral artery, sending fibers off to the lateral midbrain. Medial branches off the basilar artery feed the central portion of the pons. And we see that blood supply in this setting cutting through the brainstem, and we see that the anterior spinal artery feeds, and the vertebral territory feed these very medial structures, which are very important structures. These are the pyramids, the corticospinal tract, and this is the medial lemniscus. So this damage here would produce a spastic paralysis on the opposite side of the body. Damage to the medial lemniscus would produce numbness on the opposite side of the body. And we see the blood supply to the medulla here, and we can see the posterior inferior cerebellar distribution. It includes many of these structures we've talked about. So it includes the cerebellar peduncle, seen here, the spinal nucleus and tract of 5. So there would be an ataxia with the cerebellar peduncle, with a loss of, if there were damage to the posterior cerebellar artery, there would be loss of pain and temperature in the face on the ipsilateral side, and loss of pain and temperature on the contralateral side because the lateral spinal thalamic tract is sitting here. There'd also be damage to the nucleus ambiguus, affecting cranial nerves 9 and 10, so the gag reflex would be lost. And this is known as the Wallenberg, when this infarct of the posterior inferior cerebellar artery or the associated vertebral artery. It's called the Wallenberg syndrome or the lateral medullary syndrome. If we come down to the pons, we see that the medial pons is fed by branches off of the basilar, and the more lateral pons is fed by the anterior inferior cerebellar artery. And recognize the cranial nerve 5 comes out this way, so the cranial nerve 5 would be affected, and both the sensory and motor effects would be felt. Whereas more medially, if there's an infarct of these small vessels coming off the basilar into the pons, it would affect corticospinal inflammation that's coming in this location and these various tracts that produce a paralysis. If it's ipsilateral here, it would produce contralateral paralysis in the body. A locked-in syndrome is a syndrome in which there's bilateral damage. Because the basilar artery supplies the ventral pons, if there is an infarct of the basilar artery, it can produce bilateral long tract findings. And that's particularly for the corticospinal tract and at the pontine level, corticobulbar tract. That means that those fibers below this level of the basilar artery would be affected, and there would be bilateral paralysis below the level of the infarct. That person might not be able to move their arms or legs or speak. They might not be able to move their face because the 7th cranial nerve has been involved, the tongue's been involved. They may not even be able to move their eyes laterally because the cranial nerve nucleus 6 is at the lower portion of the pons. But it may spare cranial nerves 3 and 4. They control eye movements in a very selected way. So the person may be able to move their eyes up or a little bit lateral, move them up, but not be able to move them laterally, and yet could communicate because the central portion, higher portions of the brainstem may be preserved that include the reticular formation. So that person is in a locked-in position. They're essentially paralyzed through their entire body other than the ability to move their eyes upwards due to preservation of activity in the midbrain. But they cannot move their eyes or other parts of their body at all. This has been described in a movie and a book, The Diving Bell and the Butterfly, a memoir, and it describes this incredible activity in which somebody is alert and awake, but can't let anybody know that they're awake other than by moving their eyes.
Here's the blood supply to the midbrain, and recognize that vessels coming off of the posterior cerebral artery, as well as coming off this superior cerebellar artery, feed the lateral portion of the midbrain, and some of the more medial branches off of the posterior cerebral artery will feed the medial portion of the midbrain. Key concepts to think about in terms of vascular syndromes is if there are certain cranial nerves at each level, at the midbrain, cranial nerves 3 and 6, and their nuclei at the pontine level 5, 6, 7, and 8, then damage, either vascular insult to the pons might affect all of those cranial nerves or a subset of them. Vascular insult to the medullary vessels might affect 9, 10, and 12, as well as the long tracts that are traveling through those areas. So we were always looking for the possibility that brainstem damage causes sensory and motor deficits on the same side of the face, because the cranial nerves influence activity, sensory and motor activity on the same side of the face, whereas the long tracts have all crossed by the time they get up into the brainstem, and you'd have findings, sensory and motor findings, on the opposite side of the body. The exception for that is descending hypothalamics, descending sympathetic activity coming from the hypothalamus down to autonomic pathway, that is sympathetic preganglionics, and they produce an ipsilateral Horner syndrome, in which you'll see pupillary changes and dry face. There are a number of slides that we want to use as study material, but they tend to integrate information from brainstem and the long tract pathways that we've just discussed. You'll want to recognize each brainstem level by the shape and a few of the key features in each of those. So think about the midbrain, the pons, and the medulla, and then identify where the cranial nerve motor and sensory nuclei, where their entrance and exit is of the cranial nerve, and then the location of the long tracts, the medial lemniscus, the lateral spinal thalamic tract, the corticospinal tract, and the spinal trigeminal tract, which deals with pain and temperature on the ipsilateral face. All these others deal with contralateral findings, that is the medial lemniscus, lateral spinal thalamic tract, and the corticospinal tract. We'll look at a couple of those. So this just shows you the sections through the brainstem, starting from the most dorsal or rostral, and this is dorsal, of course, and this is ventral. But here we see the upper midbrain, lower midbrain, upper pons. We see the medulla, and then we see the spinal medullary junction. And you see the cranial nerves coming off at each of those different levels. And then you can walk through these different levels and identify some of the major structures. You see here the cerebral aqueduct, the periaqueductal gray. This is, of course, the rostral midbrain level, the superior colliculus, which is represented up here. And this red nucleus is a very distinct feature. And the medial lemniscus is lateral here. The substantia nigra is seen in this location, and the crus cerebri is seen in this position. Of course, the crus cerebri includes the corticospinal tract right here, as well as corticobulbar tract. Notice that cranial nerve 3 is coming, this nucleus is up here, and its fiber tract comes out medially between the peduncles. This is an example of a stained specimen. If we move a little bit lower in the midbrain, we can see the decussation of the cerebellar peduncle, superior cerebellar peduncle, and still see a bit of the substantia nigra, as well as the other structures. We see the spinal thalamic tract, and the medial lemniscus is coming up to that region. And we also, at this level, will see the colliculus and the inferior colliculus in this case, the periaqueductal gray, as well as the cerebral aqueduct. This is a picture of the medulla, and as we come down into the pons, you see the major nuclei, motor and sensory nuclei of fifth cranial nerve,
You see the basis pontus with the corticospinal fibers coming through here. These are corticospinal fibers. You see the medial lemniscus in this position. And you see now the 6th cranial nerve coming out medially, and the 7th nerve, the cranial nerve, comes out more laterally. This is the mid-pons. And if you go to the caudal pons, we see a little more of the brainstem, the basis pontus. If we come down to the medulla, we see now the pyramids, the corticospinal tract. We see the medial lemniscus in this position. We see the 12th cranial nerve nucleus for the tongue, medially, and then coming out between the olive and the pyramids. It's going to feed the tongue. And then we see nucleus ambiguus, the solitary tract up here for taste. And we also see the rootlets of 9, 10, and 11, important for the gag reflex. We see the inferior cerebellar peduncle. The vestibular nuclei are up here, important for balance, and damage might produce dizziness. What else we see? The spinal tract and nucleus of 5, seen over in this location, also over in this location. And the lateral spinal thalamic tract, which is carrying information, is much more lateral here, so right over here, is carrying pain and temperature from the opposite side of the body. And this is the image through that brain at the medulla level. And this is the spinal medullary junction. And here we see the crossing fibers from the corticospinal tract coming from the pyramids, and they're going to occupy a position in the spinal cord that's very laterally, and coming from the medial lemniscus, or coming from the dorsal columns, they're going to cross at this location in the medial lemniscus and occupy the opposite side of the medial lemniscus. So this is the decussation of corticospinal fibers. This is the decussation of axons from the dorsal column nuclei. This is nucleus facialis for the leg, nucleus cuneatus for the arms, for vibration and position. And here's an image of that. Thank you very much. If you have any questions, don't hesitate to give me a call or email me and stop by.